Dr. Naveen Pemmaraju from the MD Anderson Cancer Center in Houston, Texas, will be talking to you about promising new drugs for MPN therapy. Dr. Pemmaraju.
Well, thank you very much, Dr. Gayeth, and to the entire team here in New York. It's always great to be back, and a special shout out to Professor Silver. Dr. Silver, it's an honor to be here in Cornell with you and all of your mentorship and inspiration. So with my time, I'd like to dedicate my time to you, the patients, but also to the caregivers and advocates who are also here and to talk about what I believe is an unprecedented golden era of MPN therapy in our field. As you know, I'm an active clinical trialist, and so I'll be giving you some new cutting-edge, exciting things. So team, this may be the most important slide to most of you. As we end 2023 and enter into 2024, I believe that we have entered into a golden era based on the research from Professor Ron Hoffman, Professor Silver, and many others around the world to now bring to you new agents beyond JAK. And so Dr. Hoffman's talk today was fantastic because it laid the groundwork for what's entering into the clinic. As a brief overview in polycythemia vera, by the work of our European colleagues, we now have the Ropeg interferon, you know it as Bezremi, which is now approved here in the United States as a novel formulation of interferon, something postulated by Professor Silver some 3 decades ago, and now what's old is new again, a very nice formulation in the clinic. The second agent being pioneered by Dr. Hoffman and his colleagues here in New York is the PTG-300 or rusfertide, which is a first-in-class hepcidin mimetic. So trying to think beyond the JAK-STAT pathway. This is an injectable drug self-administered by the patient once a week. In ET, as you just heard from Dr. Scandura and Dr. Ritchie, both the interferon agents as well as other new agents, LSD1 and others. And then now in the more rare diseases where I spend a lot of my own time, systemic mastocytosis, hypereosinophilia, the 8p11 syndrome, starting to have approved drugs in the clinic, KIT inhibitors, pemigatinib is an FGFR inhibitor. These are approved drugs that have just been recently come online either during the pandemic or just before that are now available for prescription in the clinic. And that's based on the research from all of you, the stakeholders here. On the right side of the slide, myelofibrosis, which will be the bulk of the promise here. Can you believe it? As we sit here now, we have 4 FDA-approved JAK inhibitors. Again, that's thanks to all of you here. From now a decade of ruxolitinib in the COMFORT studies to fedratinib just before pandemic 2019, and then pacritinib and momelotinib just approved in the last 3 years. This is remarkable. The novel combo agents, which we'll try to touch on here for promising drugs, the bromodomain BET inhibitor and BCL-XL navitoclax, as you heard earlier this morning. And then now something very important to many of you as patients, the anemia of myelofibrosis, the anemia as a singular focus for drug development is now blossoming, again, thanks to all of you. Well, as you have remembered this, and many of you have lived through this, I think that the first sea change in our field of promising therapies was, of course, that of ruxolitinib and the JAK inhibitor revolution. Can you believe this is now 10, 11, 12 years old from the time of Serge and Claire and all of you, the COMFORT 1 and 2 studies? While this was a sea change and has helped so many patients, as Dr. Hoffman and others have pointed out, we did not yet cure your disease. I think this was a fantastic leap forward, but let's see through the course of these few minutes together if we can build on it. If we can remember these numbers, 42% spleen volume reduction, SVR35, at 24 weeks, and 46% symptom improvement, I think we can do better, and I think we're already doing better, and I'd like to show you that. As Dr. Hoffman pointed out, life after ruxolitinib for many of you may not be so pleasant. Now a chronic disease may become in many patients a more acute disease, either leading to the accelerated phase, the blast phase, or even to an acute leukemia. And so we must do better here. This is from Professor Palandri, our colleague in Italy, who looked at 218 patients in their database and found, I think surprisingly to many, that at 3 years, almost half of the patients have stopped taking their ruxolitinib. Stopped. Most of them for not good reasons. Only 5% or less to transplant, the majority having adverse events, infections, progression of disease, spleen, etc. And unfortunately, the median overall survival, the average overall survival is not so great after that happens. And so the concept that they found is that if you can incorporate investigational agents, clinical trials, new drugs beyond JAK-STAT, that you might possibly greatly increase your overall survival and your outcomes if you're unable to go to a stem cell transplant. Well, how do we do that? Well, Dr. Hoffman laid out the blueprint for us earlier this morning. We need to try to, in my opinion, go for disease modification rather than waiting until the later stages of the disease, myelofibrosis and leukemia, where many times it's difficult to treat. Let's try to decide together if we can intervene together earlier and at the level of the stem cell. Of course, we need to find those measurements. We need them to not be toxic, and if we combine, they need to not have overlapping toxicities. Furthermore, as you heard from Dr. Scandura and Dr. Ritchie, if we can intervene perhaps at the ET and PV stage through interferons and other disease-modifying agents, maybe we can prevent the progression of myelofibrosis in the first place. These are our aspirations. These are our goals. These are our dreams. This is who we are as a people. Now, these novel therapies are exploding, and I'm so happy to say that to you. From 2022 until now, I've had to update the slide weekly, and that's good. Weekly, okay. So I tried to put some categories here, maybe in a more patient-friendly way, just to kind of think about what the heck are these drugs. And again, Ron, I loved your talk earlier because it really set the stage for this. As you saw, when you go beyond JAK-STAT, we're trying to think about promoting apoptosis. What does that mean? That means we want cell death to happen in the bad cells. So your cancer cells, myelofibrosis cells, how about those die preserving the healthy ones? How about targeting the microenvironment, the niche, the area that's supporting the cancer or the myelofibrosis in the bone marrow and outside? There are factors, heat shock protein, CD123, et cetera, that may be helping to prop up the disease. Inflammation and activation of the TP53 pathway. Dr. Fleischman, who's here, you'll hear from her later. Hans Hasselbach, who's here. Dr. Hoffman, all of your work in and around the TP53 pathway, inflammation, MDM2. And then this huge new area that you introduced us to, this epigenetics, fibrosis, all of these areas. We have pharmaceutical engagement, as you saw outside here. We have I think, the best patient-activated community in all of medicine, really. And then now we have some new targets to go for, telomerase inhibition, et cetera. As you saw earlier from Dr. Hoffman, I think we really have to meditate and think about this imetelstat agent. This is one of the first-in-class drugs of its kind. Telomeres, you've heard about it in aging. It comes up in the regular press with some frequency. And maybe this is the first in class to inhibit this process. So we can't say anti-aging just quite yet, but at least an anti-myelofibrosis therapy. The concept, as we heard earlier this morning, is that if you can inhibit this telomerase, that maybe we can prolong healthy cells or at least get rid of some of these MF cells. And the point is that rather than going for spleen and symptoms, which I think was valiant and great for you 10 to 15 years ago with JAK inhibitor monotherapy, but may I posit to you that maybe these drugs don't work through the same pathway. So maybe your spleen and symptoms may not get better readily or easily, but perhaps we should be measuring something else. How about the quantity of life extension? So overall survival as the ultimate measure of modifying your disease, in addition to feeling better and shrinking the spleen. And Dr. Hoffman showed us this slide in that this was the first hint that we got that maybe a novel agent can do this, and overall survival was improved at the appropriate dose. This is now remarkably in a phase 3 trial. And for the first time in our field, this is a big win for our patients. The primary endpoint is overall survival. I want to repeat that. For the first time in our MPN field, the primary endpoint of a phase 3 randomized trial is your overall survival. That's a moment of celebration for our field because now we can say confidently that we can test hypotheses that try to prolong the life of the patient, not a surrogate marker, not a hypothesized marker, but actual survival. This is a relapse refractory study. It's best available therapy against the new agent. It's pending. Let's see how these results are, and let's see if we can transfer this protocol and this program to our other pursuits together. In that goal, the MPNRC, the research consortium led here in New York, Dr. Hoffman and colleagues has really been a pioneer to bring new drugs from the lab to the clinic in, I would say, record time, and this is admirable and something that should be celebrated. One of those examples is this new story of the Reparexin, which is in patients with MF, MPNs, preclinical rationale, as we heard earlier from some of these drugs, is generated in the lab. Basically, just to remind us, the concept is that we must test these in cell lines and in animal models to show that these drugs have activity before bringing them in the clinic, as you're familiar. The study design for this new agent is shown here. And again, I'm showing you this slide to show you how great it is to take translated findings from the lab directly into the clinic. And this study will be opening here. Another example of this targeting inflammation, fibrosis, and before the disease becomes advanced is the canakinumab. Canakinumab is an interesting story. It has an FDA approval for something very rare like familial Mediterranean fever because of its anti-inflammatory benefits. So can we repurpose and take drugs from other experiences, put it into our MPN patients for benefit? After all, if we believe that inflammation is at the heart, why not take anti-inflammatory drugs that are already out there and repurpose it for our patients? And so the study rationale for this canakinumab is it's approved for this rare inflammatory non-cancer state based on a pathway called IL-1 beta. Well, we found that it's overexpressed in MPNs. This is a marker of inflammation, and it preferentially supports the mutant MPN stem cell. And so can we administer this canakinumab agent, which, again, this IL-1B pathway appears to be contributing to clonal expansion and progression of myelofibrosis. So this trial through the consortium will be opening at multiple sites. And again, the study schema is shown here with very nice stopping rules for patient safety, which is important as we measure new drugs. Let me say that as we have the excitement of the new drugs, we also have the sobering reality of making sure your safety is paramount. New drugs will bring new toxicities, won't they? We know that. If they get approved, they'll bring financial toxicities. We know that. And if they're combined, then they're going to have combined new toxicities that no one predicted. Only you in this room know that. So that's something that we pledge to you, that when we make these trials, stopping rules, if it's too unsafe, the drug and the trial is on hold. Futility rules, if it's safe but it's not working, it goes on hold. So remember that. Well, that features now this combination era. So if you're not excited yet, I want you to get excited about this, because this is something I personally think is fantastic for the field. So first breakthrough, JAK inhibitor is great. I would actually say first breakthrough is interferons, then JAK inhibitors, now combining and looking at the new drugs. Again, this is having to be updated monthly. The two that are furthest along is the navitoclax and the pelabresib of the newer agents, but let me just give you a flavor of some of the other ones as well. So I think very importantly, as we meet here in November now already, the end of 2023, is this BET inhibitor bromodomain. You heard it from all of us today. I think the concept is what's important. MPNs, myelofibrosis, disease of inflammation, not a disease of aging, disease of inflammation. So you have aberrant pathways, cytokines, these protein messengers that have gone awry in your body, aberrant red blood cells, aberrant megakaryocytes, which you'll remember are the precursor to your platelet cells. And this BET inhibitor bromodomain aims to restore these pathways. This agent is known as pelabresib, really being led by several here in New York, John Mascarenhas and Rajith Rumpel. I want to show you the most important data that I've seen so far, which is in this Manifest Arm 3. This is frontline data, ruxolitinib plus this new agent pelabresib. So combination, frontline to patients for the very first time. This is some 84 patients treated. And you're starting to see spleen volume reduction that we have not seen before. I think I made you memorize the comfort spleen. Does anyone remember? What was that? I made you memorize it, 42, and 46 was the symptoms. Good, Dave. So this is 68%, guys, 68% spleen volume. In the waterfall plot here, just to remind you, each line is a patient. So almost all patients are having some form of response with the combination. But what about symptoms and toxicity? I owe you that. Symptoms are very respectable at 56%. And the drug combination thus far has been extremely well tolerated. I'll show you that in a moment. What about disease modification? If we're going to give you a second drug, we have to justify why are we doing that for you and for us. Take a look at this. Early on, this is 12, 24 weeks, you're already starting to see the signal of bone marrow fibrosis reduction very early on. We didn't see that in the JAK inhibitor monotherapy experience. And then the side effects, as I mentioned to you, generally well tolerated for most of our patients. There is a GI toxicity that we see in most of these novel agents, including this one. So it can be diarrhea, nausea, vomiting, can be managed. And then there is some signal of the platelets and other markers can go down with the blood counts, but they can recover quickly. A second agent to highlight to you as patients and caregivers is that of navitoclax. You heard that earlier. That targets a pathway called BCL-XL. The cousin pathway gets all the press, all the attention. Okay, that's BCL2. So many of you have heard of that. That's venetoclax, and that's the one that's FDA approved in both CLL lymphoid cancer as well as AML older patients. But BCL-XL is the forgotten cousin, not for us, okay, not for us, because in MPN, it does appear, for whatever reason, that the BCL-XL is a bit more active. And so scientists have shown around the world that this could be something for our patients. Let's take a look and see what happened. Well, in a in a phase 2 trial, Professor Claire Harrison and myself went for targeting with this drug. And what we did first was we took 32 patients who were suboptimal. So that means you're already on your Rux for at least 3 months, and it's sort of working, sort of not. Is that resonating with you? So you're not having that poster response that everyone says, oh my gosh, I'm jumping up and down. You're having a mixed response, suboptimal. And so then we added in the navitoclax, an oral agent, as an add-on to those patients. It took a while to find those exact patients, 32 patients in a fairly long period of time. It opened up right at the start of the pandemic. We were able to publish those results in one of our prestigious journals, but I wanted to show you why it was so important, is that we focused on overall survival. The spleens decreased, the symptoms did improve, but not as shockingly as the overall survival improvement. So many of these patients, because of their high-risk nature, ASXL1 mutations, et cetera, were thought that may not have as good outcomes. So at 2 years follow-up, the median overall survival was not yet reached, which means that patients are still alive, active, now 2, 3, 4 years later. And so I think the concept here is that you can add in a second drug and start to modify the disease. We then looked further, my colleagues and I, what exactly does that mean? How did we modify the disease? And in these 32 patients on this phase 2 REFINE, we looked at the patients who had the most overall survival benefit. I realize it's a small group of patients, but in that small group, we found that those patients correlated with whoever had the most improvement in their fibrosis or the most improvement in their allele fraction burden, the JAK2 number itself. This suggested to us that maybe we're onto something here, that everything correlated: spleen, symptoms, variant allele fraction, fibrosis. Can't make any conclusions based on this, but at least we have a signal that this may be working at the molecular level. We then took this combination into the proper frontline setting, still in the phase 2. So now the combination, the ruxolitinib plus this new drug, navitoclax, still in phase 2, about 32 patients again, a new set of patients. Almost all had a spleen volume response. Almost all had symptom benefit. And then a third of the patients who had the spleen response also had bone marrow fibrosis reduction. So if we're going to talk about disease modification, let's start to see it. Let's start to see things that matter to you as the patient: spleen, symptoms, overall survival. And let's see things that matter to the scientist level, that things are actually moving in the right direction. So what do you do with all this information? Those two programs that I just mentioned to you, the pelabresib bromodomain and the navitoclax BCL-XL, are now in ongoing phase 3 randomized studies frontline. So combination against ruxolitinib alone, and we'll hear about that data at the ASH meeting, which is just next month somehow in December, right? It's just a month away, and we eagerly await that. For you as patients and for us in the field, it will mark the very first time ever that we'll have data on randomized phase 3 trials that compare against ruxolitinib as the standard of care to ask the question, is a combination upfront better for me or not? Does it delay the disease better, faster, deeper? Is it worth it, et cetera? With the remaining time, I just want to give you a flavor of the rest of the field, which is now exploding. There are other new pathways. This is called XPO1, another new pathway that shuffles in and out of the cell, and this is a drug called selinexor. A great example of a drug that was approved somewhere else, lymphoma, myeloma, has some toxicity, unfortunately. GI toxicity can cause fatigue. Yikes. Who wants more fatigue, right? So in our disease for MF, the sponsors and the investigators nicely drop down the dose. So it's a weekly drug, lower dose. Selinexor is the name, combining with Rux. And I think to many of our surprise, I'm not directly involved in this trial, almost all patients early on had this spleen volume reduction. This is frontline patients. And so the concept is now this is also going to larger studies, phase 2, phase 3. So selinexor, we'll keep our eye on that. Another promising agent, as mentioned by Professor Hoffman, is the MDM2 approach. Navtemadlin is the current drug with the Kartos group. This was presented publicly now at the EHA summer meetings in Europe. And this Kartos drug, Navtemadlin KRT-232, again, very nice development from Dr. Hoffman's preclinical work, I think now spanning 2 decades, if I'm not mistaken, that you've been pioneering this field. This MDM2 approach, now you have a well-tolerated agent. The dosing and everything has to be adjusted around the GI toxicity from the early experience, both single agent and now again combination. And again, you're seeing a growing theme that we're starting to see disease modification early on with the addition of these novel agents. And again, this agent is now moving into phase 2, phase 3 clinical trials to really show once and for all if there's benefit to you as the patients. I have to mention interferon. We're here, after all, at the house that Professor Silver built. I am so excited about this, as I know Dr. Silver is, which is the Ruxo-PEG study led by Jean-Jacques and our European colleagues. I love this. They were criticized so heavily, as many of you know, oh, you're going to introduce too much toxicity to the patients. Okay, so they made a smart study, adaptive Bayesian design. Safety was the primary goal here. If there was any toxicity, they would have stopped everything. In fact, they did not find that. What they found is that it was a well-tolerated regimen, that patients benefited, of course, with smart design and study. And guess what? What's my theme here? Disease modification. We already know that interferon did that. Dr. Silver showed that 35 years ago. But the combination of the two led to very deep molecular responses with the JAK2 mutated patients in particular, which were durable and correlated with disease modification. Dr. Guyeth here is going to continue to lead, that effort with this interferon approach here in New York. And so what I leave you with is, in this golden era that I promised you, I hope you share my excitement. You heard Dr. Hoffman's enthusiasm and optimism earlier. Ladies and gentlemen, I'm ready to posit to you that we are now ready for a new era of cure, of disease modification, of improving overall survival. Let's build on what the earlier generation started for us with spleen and symptoms, and let's go for overall cures together. I think as we look at the rest of the field, there's so much excitement. I think some of these slides didn't come out, but there's so much excitement with immune therapies, as you heard. Dr. Hoffman gave a few slides there. So targeting the CALR by itself, maybe even more specific approaches to the JAK2. And I do want to put a plug for drug repurposing or borrowing. There's nothing wrong or bad with that. What it means is let's keep looking together what's happening in AML, MDS, and other fields, and let's use that in our patients to their benefit for whatever is affecting them. And so with that, I'd like to thank all of you as our patients, but also a shout out to the caregivers, all the advocates here. All the stakeholders are here in New York this week for one goal. Let's cure these diseases, MPNs, once and for all, and let's make your lives better, longer, and happier. Thank you very much for your time.
Thank you, Dr. Pemmaraju. Wow, a lot of new developments. Actually, if you go to clinicaltrials.gov and you search myelofibrosis, you're going to get hundreds of trials actually in the U.S. Or studies in general. So it's exciting to hear. Obviously, the question I think on a lot of patients' minds is, how do I choose? So that's where you see the experts and you get their opinion. So we're still trying to figure that out. How do we choose? It does get quite complicated with all these studies.